You say you were...
That's why, yeah, that's why I had that extra 30 or 40 degrees.
Yeah.
In the external and the internal.
Comes at the expense of something.
Yep. Let's see what happens here. Lateral upper arm is my go-to pattern to improve both ER and IR, but more likely than not, because most patients are falling into the rapidly responding category, which basically impingements fall into. You know, you're gonna have a loss of IR, so much to the point that there's actually a syndrome, right now, GERD, glenohumeral internal rotation deficit. Yeah, he has more ER, he has a loss of IR. But again, most of them, I'm willing to bet he has the IR. Because I didn't think he had his cervical range of motion, but he did, right? Just because his scapula pops up like that doesn't mean he doesn't have this. So lateral upper arm, it's more restricted between anterior deltoid and bicep, and lateral bicep and tricep, and you can all feel that on yourself. For some reason, the lateral upper arm between bicep and tricep and medial upper arm between bicep and tricep, call it the IT band of the upper quarter. We're not changing this, but for whatever reason it's more restricted. Let's try to change the tone on this, try to work on a couple superficial restrictions, and see what happens to his IR. So I want him to be relaxed, so how about that? Is that okay?
Yeah.
So there tends to be more restrictions right around this junctional area here. And again, because I just don't have my stool to roll all around him, normally I don't stroke like this. I usually always try to stroke away from me because it's better mechanically. If you want to use an assisting hand, you can actually pull away and drag the tissues away for a little bit more stretch.
Reminds me of that IPA.
Is an
talk about
IPA
that
thing.
if I'm on.
Mm-hmm. So I didn't invent anything. Just a package.
So would you call that like moderately limited in ER and IR? Or major
Yeah, I would
limited?
say it's like a DN, moderate limit. It was DN, right? Not painful?
No, not painful.
And AC did nothing for this room. I don't think it's on. You guys warm? I'm warm. My clinic is like 68 normally. In Texas, when I was warm, everyone else was cool because it was like 75. They're like, dude, it's only 120 degrees here. Like having a room that's 75 is pretty comfortable. But 75
that wasn't hard with your patients keeping it 68 and having things where
they potentially have an
expose
AIG.
more areas and stuff like that.
Well, I don't know. Yeah, I mean, you know, guys feel it's comfortable and girls think it's cold. It's a generality, but that's just what it seems like. Okay, so I'm making sure to stabilize the scapula again. Just relax, Eric. That's definitely better. All right. Because he was like up here before.
Mm-hmm.
So, and let's try to lock this in with a repeated loading strategy. Actually, one more thing. Bonus technique. I used to dig in on the pec minor, and I used to say that, you know, this is the nice way, and this is the not nice way. Now all I know, all I'm doing is changing tone. So let's just lightly pin this and push back into me. So let's use some reciprocal inhibition. Push backward into me. Better? Better than when I was pinning it before, right?
It doesn't hurt. Yeah.
Okay, and relax. And push back. And relax. And push back. And relax. Okay. Relax again.
Yeah, it feels looser.
Oh yeah.
It's way looser.
It's looser. Right. So you
It's
already had it.
amazing.
No, it's not. It's simple.
My arm hasn't been there since I was probably 12.
No, you had it though. It's not adhesions, right? It's not a slow responder. 90% fall into a rapid responder. It's not amazing, it's just simple. That's all. Is simple and easy amazing? Or is it just simple?
It's amazingly simple.
It is.
Profound.
It is.
Simply amazing.
Simply amazing. It is. See, these are all like, could you, like, man, we got to put these on like a course brochure,
Yeah.
right?